Hello, everyone. In this question, we have a 68-year-old male. He's been experiencing palpitations, and he also has progressive shortness of breath, choking sensation, and dry cough and lying down. Now, these are all symptoms of heart failure, and he also has crackles on the lung exam, so he has fluid in his lungs as well as pitting edema. So he clearly has heart failure, and he's also been experiencing palpitations, and he has a irregular rhythm. So this is going to tell us that he also has atrial fibrillation, and when we take a look at his medical history, he has hypertension for the last 20 years. His blood pressure on exam was 180 over 100. And the echo shows normal sized left ventricle with wall hypertrophy. And he has a normal ejection fraction at 55%. So this is greater than 50%. So this is indicative of heart failure with preserved ejection fraction. Now, the question is asking what is most likely causing this patient's symptoms. Now, heart failure with preserved ejection fraction is going to be caused by diastolic dysfunction, so the answer is going to be answer choice A. Now, let's take a look at this image. Now, at the end of diastole, let's say that we've filled the left ventricle with 100 milliliters of blood. And let's say that we've been able to eject 60 milliliters of blood. Now, this is going to give us a ejection fraction of 60%. Now, so let's say 60%. Now, this patient has been experiencing hypertension for the last 20 years. Now, with hypertension, the left ventricle is going to have to work harder in order to eject blood out of the ventricle. And the reason for this is because the pressure in the left ventricle has to be higher than the systemic pressure in order for the aortic valve to open. So, as a result, over time, the left ventricle is going to hypertrophy because it has to work harder in order to generate that extra pressure to force that blood out of the left ventricle. So sarcomeres are going to be added in parallel, and then we're going to get this um, thickening of this left ventricle wall. Now, when we have this thickening of the left ventricular wall, now during diastole, we're going to be less able to fill this left ventricle. So because now this thickened wall is occupying space, we're only, let's say, able to fill the left ventricle with 50 milliliters of blood. And let's say that we've been able to eject 30 milliliters of blood. Now, this is still going to give us a ejection fraction of 60%. So this is heart failure with preserved ejection fraction because the ejection fraction is preserved. But remember that we are only sending 30 milliliters of blood to the rest of the body compared to 60 milliliters of blood here. Now, because this occurs in diastole, because we're not able to fill the left ventricle with blood during diastole when the left ventricle is supposed to fill, this is diastolic dysfunction. Now, what we need to know is that atrial fibrillation is going to be a big risk factor for exacerbation of heart failure with preserved ejection fraction. And the reason for this is because during the end of systole, or excuse me, during the end of diastole, there's going to be this atrial kick that is going to cause more blood to go from the atria into the left ventricle. If the atria is not able to properly contract, like in atrial fibrillation, then we don't get that extra volume flowing from the atria into the left ventricle. As a result, what occurs is there's less blood volume found within the left ventricle, even less than the low volume that the person has been getting. So as a result, they're going to experience an exacerbation of their heart failure symptoms, and that is what the patient is experiencing in the question. So the answer again is going to be answer choice A, diastolic dysfunction, which is causing this patient's symptoms.